Hey, Mike Gibson, Brittany Weber, and we're talking today about imaging and atherosclerosis. Brittany, you and I have a lot in common. We both were born in Oklahoma, grew up in Oklahoma, you in Piedmont, Oklahoma, me in Stillwell, Oklahoma. So we got a show today brought to you by two Okies today.
I
So
love
good to
it. Yeah. Thank you so much, Mike, for having me. And I love it. I love getting to meet fellow Oklahomans. And, there are more than us than people realize. But if people haven't visited, take a look down those.
exactly.
Yeah.
I'm a plumber, Brittany, and I'm like, there's this guy on TikTok, ortho guy, that kind of, he's this kind of primitive caveman. I fix bones. I fix blockages, but blockages aren't, yeah, they cause symptoms, but I think we're moving into a post-blockage world, into more of a plaque world. When I was growing up and was at the University of Chicago, my pathology teacher who used to stare into the microscope with me was Seymour Glagoff. And of course,
Yeah.
there's the Glagoff phenomenon that you get buildup of the plaque around the donut hole until the plaque gets to be about 40% of the total volume. Then you begin to grow inward. So, and about 70% of MIs aren't at the site of those tighter obstructions. They're in those vulnerable plaque areas. So, at a stress test, I grew up in a world of stress testing to
Yeah.
find blockages, but I
Yeah.
don't know that that does as good of a job of looking at risk due to plaque, and it may not be obstructive, right? So, talk to us now about 2026 and risk assessment and what value imaging provides on top of some of the things we've been doing in the past.
Yeah. Well, one, just thank you. And you alluded on so many important points. And, work in a unique intersection where I trained as an immunologist and I specifically take care of patients with systemic inflammatory diseases. These come across from the rheumatology field all the way to the dermatology field. And, I have utilized imaging both in my research, but also in my clinical practice. And to get to your point is, exactly. We have to, I think of this as a fundamental biologist that we have to be reframing coronary artery disease. And it's not as much this traditional model of stenosis, no stenosis, obstruction of obstruction, but what is coronary artery disease? And fundamentally, it's a disease of atherosclerosis. And, when I think about this and I explain this to patients, it is we want to understand the biology and detect atherosclerosis. And so what are the tools we can do that? And so just as you alluded to, we know that many events, most do not come from those narrowing, and that it's about the plaque vulnerability, not about the actual number. And of course, I don't think we have to go through all the concept of the risk scores. I'm not saying I don't use risk scores, but I also have to fundamentally appreciate that, the risk scores are at a population level. And I'm sitting here with my patient with young lupus, and I'm not going to feel reassured, when this number is spitting out at me, and based on everything she's telling me. And so when I talk to my patients about this, and I also and I'm using imaging in clinical practice, I talk to them about seeing the disease. And you can think of it as an analogy as, um, something as far as fetched from cardiology is like dermatology, right? When they're treating skin diseases, they're measuring the disease and they're targeting their treatments, and they're seeing the patients. I can even do these assessments, and they're looking at how good their skin is reacting, such as psoriasis. And that's how I explain to patients is what, we want to see the disease, the atherosclerosis, and then, and that's where the field is like when we're intensifying therapies, is that as we have more and more ways to detect plaque, quantitative plaque, measuring the different components of plaque, that's where we can start to track how these things change over time.
Well, the perverse and odd thing is everyone's getting a calcium score, and they're worried if their calcium score is high. My calcium score is high, by the way. Uh, but it's not the calcified ones that are going to get you, it's the soft ones, right? So isn't it an odd kind of paradoxical thing?
Yeah, it's and I agree. And, I think calcium scores are very good and strong prognostic tools, right? We know that. And I utilize calcium scores in my clinical practice.
But do
And
you stop there? Do you stop at the calcium score? When do you move
yeah,
on to get more of this plaque volume and
yeah,
atherosclerosis?
and it's a good question, and I will say that it's not like there's one script I will do in clinic. I think that it is absolutely a good measure of overall plaque burden, and so but so if you're just talking in prevention, asymptomatic, it is really where there's high risk patients, indeterminate risk patients who are not sure about therapy, where I'm clearly going to be changing, and also I have to make the point that even I do, I do use calcium scores, of course, even in my field, as a cardiorheumatologist, but we also in areas of like rheumatoid arthritis, we know that these patients have higher rates of non-calcified plaque, right? The plaque that is not visualized there. And this is the vulnerable plaque. And what I find most exciting is not only do we have new and more advanced imaging technologies to detect and to quantitate and to understand that plaque, we equally have more and more therapies that we can be targeting for our patients. And so that's really where I see, so many of these tools, being married. And that's why I think we have to be focusing on using, imaging as a way to see disease in our patients with atherosclerosis.
I thought you brought up a beautiful example of derm people. People can see their skin, the patient can see their skin, but what we're showing
Exactly.
them is the skin of their arteries in a way, right? And that's a powerful tool to say, here's what your skin looks like inside your arteries.
And I've used in it, and I've used that analogy because I you know, I I also take care of, for instance, many young and many young women. Many autoimmune disease has a female predilection. We already know the data by plaque biology in women it can be different. And when it is such a strong, and I will tell you, there's so much hesitation that our patients come to us with these therapies, right? You just Google statins, and a patient who's got arthritis, they're terrified. They don't, they don't want a doctor to just come in and just say, oh, you got to be on one because you have this disease. And so I really work with my patients and say, listen, like we're going to understand. I don't want you to have that event. And so if we see plaque, the disease is there. So let's work together over these next, 50 plus years of your life to do everything we can to modify, protect, and prevent anything in the future, because I don't want you at that age to be having that MI. And that's really where this is where I do prevention, right? Because my goal is to prevent. We know these patients, we know patients these are having these events. And so we want to be seeing the disease and treating it before.
Yes, usually I talk to cardiologists. It's so fun to talk to a cardio, rheumo, dermo, cardiologist who's bringing all those inflammatory arrows together. Also great to have an Oki on the show. Brittany, thanks for joining us today. Thanks for your insights.
Thank you so much for having me.